Good morning, everybody, and welcome to UNC Health COVID-19 Game Changers. My name is Leslie Nelson Bernier, and I have the privilege of serving as the president of the UNC Health Foundation, and we're delighted to have you join us this morning. This is the seventh in our Game Changers series, and you're in for a real treat today. The last time that we were all together was October, and I know many of you have joined these calls previously. So a lot has changed between then and now, and I know our speakers will be anxious to update you accordingly. I just want to reiterate that the question and answer feature is open on this call today, so please feel free to submit your questions there. You're also welcome to talk on the chat, so if you have something that you'd like to say to the other participants on chat, feel free to do that. We want this to be an engaging, interactive experience for everybody. So now it is my pleasure to introduce the Dean of the School of Medicine and CEO of UNC Health, Dr. Wesley Burks, and he'll introduce our speakers and get us started. Dr. Burks?
So good morning, and thank you all for taking the time to join us. And Leslie, thank you for getting us started. After the really interesting and informative game changer sessions we had in the year of COVID 2020, I'm thankful to be back with you today in the new year, joined by two really important people in our School of Medicine and UNC Health. First is Dr. Joe Eron. He's a leading infectious disease expert and the head of our infectious diseases group. Joe spent the last year totally immersed in COVID, both clinically and from a big picture research standpoint. And then Dr. J.M. Baratta, who's a leader in our field of physical medicine and rehabilitation, who is helping us address the growing problem of the long-lasting effects of COVID in our patients here locally and throughout the state. Both of them are helping to change the future of COVID-19 for all of us locally, throughout the state, and really nationally. As we did during the previous sessions, I wanted to start by offering an update on the current state of COVID-19 response across UNC Health. At the moment, we have a lot of reason for hope and encouragement. We've seen a huge decline over the last month in the number of hospitalized patients in our system. The upward trend started, as you know, in early to mid-November, continued through Thanksgiving and Christmas and the first of the year. And only in the last month, we've seen a significant drop in patients that are in the hospital, which has been really encouraging. And I anticipate wherever you are, it's been somewhat like that there. 1 minute, if you'll allow me a personal reflection. I was in the room here at the Medical Center Hospital on December 15th when we gave the first vaccine doses to our frontline coworkers. And as I walked over there, I thought a lot about it, but I didn't anticipate how the emotions really came through. And I've shared this with others, that sense of relief, of hope, literally getting choked up, and I wasn't even talking, just being in the room to watch and think about what really had happened in such a quick period of time. We'd been 9 months into it and we had no vaccine, and we actually had 2 vaccines, and we were able to give it despite all the turmoil around it and the problems that are still there. But we were able to give a vaccine to people to help protect them. I personally, in my turn, several weeks later, got the vaccine, and I again told others it brought back childhood memories for me and the polio vaccine, getting it the first time. I shared this with others recently that it was, for me personally, an iconic moment sharing with my dad, who got the coronavirus vaccine at the same time, literally in Arkansas when we did here. And I told him about, I had a memory of the polio vaccine. And he very clearly said, oh, I remember where we were living. I remember where you got it. I remember how it all happened. He said that, and it's not something that he, in his 90 years, had ever reflected with me before, that as a parent, I was so concerned that you were going to get polio. To see you get that vaccine was like a watershed moment for me as a parent. And that's how I think all of us feel right now, and getting this vaccine to try to go forward. So big picture for us for the vaccines, we've given as a system over 170,000 vaccines since we started mid-December, which is really pretty amazing. like Joe and JM will talk about, when we get to the other side of this, whenever that is, and we all can speculate on when that might be, the university, the School of Medicine, UNC Health. We've had people that we work with here that have done some amazing things and really have been leaders to try to help us get through this. Our teams from the school and the healthcare system have set up 17 sites to give vaccines all across the state. We have one here for those of you that don't live locally at the Friday Center. We have some in Wake County and other places. I've been there several times. I volunteered last week, and it's amazing to see the people coming through and the fear and the emotions, but the excitement, the comfort of being able to get a vaccine. So thank you again for being with us. As we started each of the other events like that, I want to start by asking our guest a question, just to meddle a little bit. So how are you doing personally as we now approach 1 year of living with this pandemic, which is kind of hard to say. It feels like a decade in many respects, but it's been a year. So JM, I'll start with you. So how are you doing personally?
Thank you. I appreciate the opportunity to be here today. I'm doing well personally, all in all. I know that life is very different for me, both personally and professionally, and I'm sure it is for most everyone on the call. Prior to COVID, my primary role at UNC was neurorehabilitation. So I was managing the rehabilitation of people with neurologic injuries, including strokes and brain injuries. And all of a sudden, in the early part of last year, when the pandemic started, my work changed significantly. I was redeployed and moved out of my prior settings in the rehab unit and the rehab clinic to do consultative services throughout the hospital. And basically, I was assessing the rehabilitation needs of people on units throughout the hospital, people who were recovering from COVID and from other diagnoses. So that was a challenge for me, both professionally and personally, to be doing something so different for much of last year, actually. Now, as we've been resuming a more normal way of life and been able to get back more so to our prior practices, I've been able to get back to taking care of my neurorehabilitation patients, but am also now caring for this new population, the post-COVID patients. I've found it very, very striking, all the different types of issues that they're coming in with, and I'll share that with you more later during my presentation. Thank you.
Jane, thank you. So Joe, how about you? How are you doing?
I'm doing great. I mean, it's so interesting and exciting and different. I'm a little tired, to be perfectly honest. I think for me, it's that time thing that you mentioned. Over the weekend, I was asked to, for one of our different grants, I have to summarize what we did last year. And I couldn't remember when last year was. I mean, really, I couldn't. I honestly was like, was that really last year? I mean, it seems so long. And I can't imagine for people who've been isolated in their homes and how hard that must be, or people who are isolated from their families. Two of my children joined a vaccine study, which I think is super exciting and brave of them to do it. So that's exciting. And every day there's something new. It's just crazy. We think we know what we're doing, and then tomorrow we won't know what we're doing. We'll have to think again. So it's exhilarating, exhausting, but I love doing clinical care and I love doing clinical research, and that's what I'm getting to do. So it's really great.
Yeah. Good. And I know for all of us that I've said this before, just as trying to give an example of how most of us that work here feel. If you have a new computer and you charge it, it says 100% at the top right, and it lasts for 4 or 5 days, but it's at 100%. It kind of slowly goes down. What we felt like is an old computer, and it says 100%, but it goes away in about 3 hours because the battery's just worn out. And hopefully that's not too trite, but I think hopefully that expresses how I know JM and Joe feel and a lot of people that I work with. So Joe, you've done some, and your group have done some like unbelievable things through the year. I call different people that you work with every couple of weeks just for me to be encouraged to learn about the science of it. So if you just like talk to us about what's been going on.
Sure. I'm going to share my screen and put it into presentation mode if I'm lucky. Let me know, does that show up for people? Great. So first of all, this is really wonderful, and I appreciate the opportunity. I'm gonna go pretty quick. There's just way too much to cover in a short period of time, so I'm just gonna hit some highlights. And since there's so many people out there, I don't know exactly what you want to know. So just get ready to ask some questions. I'm gonna just really quickly say where we are in the world, in the United States, in North Carolina, in the medical center. And Dr. Burke's already told us kind of where we are at the medical center, so that'll be quick. I'm going to be a little bit provocative about the spike protein. Some of you are going to get a biology lesson, but it's not very complicated. And then I'll talk about those other things up there. So it shouldn't take me too long. So this is where we are in the world. It's just incredible. I'm sure some of you have been to this Johns Hopkins website, but we're talking about, you know, over 100 million documented cases in the world, and so probably that number is really several times that, because obviously there are many people that haven't had their infections documented, and the over almost 2.5 million deaths globally. And again, that's almost certainly an underestimate, and there really isn't any part of the world that isn't affected. We do work in infectious disease all over the world. We do work in Africa, Central America, South America. Really, it's Southeast Asia that probably has the fewest cases, which is really kind of ironic. We have a site in Vietnam that has almost no cases. So it really, but it's everywhere, and it's impacted, I think, probably virtually everyone. In our Malawi site, very rural, poor country, there was a huge surge after the holidays, and many of the people that work for us became sick, and it's just everywhere. Here's kind of where we are in the U.S. I can point, and as Dr. Burke said, deaths are dropping, cases are dropping, deaths are dropping. And then if we look in North Carolina, you can see this is positive cases dropping dramatically. But I do want to point out that here we are now over here on the right. And remember, we thought things were kind of really crazy this summer. We're still well above where we were this summer. So there's still a lot of COVID. And so we really need to be careful. And I'll talk about that. This is the number of deaths in North Carolina. The reporting, you have to be a little careful about reporting in the last few days, but it's clearly dropping, which is awesome. We are taking better care of people, which I think is and people are leaving the hospital, which is wonderful. And our ICU people and our hospitalists are fantastic. And you can see the hospitalization rate across the state really going down dramatically. And as Dr. Burke said, at our healthcare system, at our medical center and across our healthcare system, it's really the same. Though our ICU still has lots of very sick people, both with COVID and post-COVID in our ICU. And I think it'll stay that way because we really take referrals from all over. So now I'm just going to say 2 seconds about the spike protein. I'd be curious to know if someone hasn't heard about the spike protein. The spike protein is the protein on the surface of the coronavirus. And it really is the key reason why COVID is such a problem. This spike protein binds to something called ACE. ACE is a receptor that we have all through our respiratory system, our lungs, our upper respiratory tract, and actually some other cells like endothelial cells and cells in our gut also have this ACE. And this particular spike protein on this particular coronavirus binds super well to this ACE receptor, this ACE protein. And that's how the virus gets in the cell. And the other thing that's really critical about this protein is it's what our immune system targets. It's where we get antibodies, because antibodies that bind to this block this interaction and prevent the coronavirus, the SARS-2, from entering our cells. So this is like really the key kind of place where the interaction between virus and our immune system is happening. And it affects everything else that I'm going to talk about today. And it really is super fascinating. So I'm going to just mention vaccines quickly. I'm only supposed to talk for 10 minutes or so, which is hard for me, but so I'm going to go quickly. I really appreciated Dr. Burke's talking about his experience with the vaccine and what the memories it brought back for him. I don't think it's really hard to conceive that it took less than a year to develop these vaccines. It's just unheard of. And then you get results like this. Now, I get these are kind of scientific diagrams, but this is basically the number. This is from the Pfizer vaccine over here on the left-hand side. And this is the number of cases. There were 20,000 plus people in each arm, a lot of people. Every little box is a case. And remember, people were vaccinated at day 0 and day 21. And this is just unheard of. The fact that the people that got vaccinated, you can see really about day 10, which would be 3 days after the first vaccine, the numbers start to change. This difference you can see, and you can see it even before people got the second vaccine. And then it persists, this dramatic prevention of cases. No vaccine is perfect, at least as far as I know. So people can get infected after being vaccinated, and people may have questions about that. In the Pfizer study, there was even one person that had a more severe illness. Most of these people had very mild illness, but this difference is remarkable. It's about 95% effective, which is crazy. The other question that comes up is, well, how long will this last? Now, these are data from the Moderna vaccine. They're both mRNA. See, mRNA is message RNA. What's the message that these vaccines are giving? The message is that spike protein. So what I showed you before, we're showing the body that spike protein by sending in the blueprint. Our cells make the spike protein. Our immune system breaks it up, and we create antibodies to it. But it's the spike protein. That's the message. And here is the persistence of antibodies out to 119 days, which is almost 4 months. And you can see that if you look at binding antibodies, or you get neutralizing antibodies, now neutralizing is what we want. You can see that it persists, though it does come down a bit, especially if you're a little bit older. But it does persist, and I'm sure people might have questions about, well, how long is this vaccine going to last for me? And that is an excellent question. We will have other vaccines very soon. The FDA is talking about Johnson & Johnson, I think later this week, and it will be approved. The FDA briefing has come out. This vaccine is nice because it's a single dose. Now, it's less effective in terms of preventing any symptomatic infection, but it's equally effective at preventing severe disease. So that'll be interesting how we message that to people. And then it's not clear to me which is going to be next. We worked really hard on the Novavax vaccine led by Cindy Gay. This is also a spike protein. These are all spike protein based vaccines. And our group helped enroll 30,000 people in 6 weeks, which is really also just not heard of. And we'll see whether the Novavax vaccine works. We didn't enroll, we only enrolled a small fraction of that 30,000, but we even got down in Chatham and tried to reach people who were less likely to be able to participate. So that was a good thing. And so one question is, well, how much vaccine is needed to provide what people want to call herd immunity. If we get enough people vaccinated, will we stop the spread altogether? On the left is the number of vaccine doses per 100 people. What does that mean exactly? So if you vaccinated everybody in the country, this number should be 200, right? Because there's 2 shots per person. So in Israel, I think this would tell me they've probably vaccinated a little over 40% of the population, which is pretty amazing. In the US, we know that about maybe 7% of people have gotten 2 doses of the vaccine, and somewhere around 15% of people have gotten at least 1 dose. So we're not as efficient as they are in Israel. Israel's a lot smaller place than the United States, but it really we'll see that already the numbers from Israel suggest that the number of new infections is dropping dramatically. But I'll remind you that the number of new infections in the United States is dropping dramatically too. So we're not sure yet how much is the impact in Israel based on vaccination, but probably some. And here are kind of herd immunity threshold for a bunch of different things. There's polio, Dr. Burke's favorite. People have estimated that about 75 to 90% of people need to be vaccinated to really get herd immunity for polio. And for SARS-2 or COVID-19, people are estimating around 80%. Dr. Fauci, America's doctor, says between 70 and 85%. And so that hopefully we'll get there. And as Dr. Burks mentioned, we are really getting vaccines out there. The total doses is 170. I'm sure this was from 2 days ago, so I'm sure it's over 170,000 now across the UNC Healthcare, and almost probably 72,000 people who've been fully immunized. I will go over to the right here and just mention that this is the workforce of our healthcare people, and what makes me a little anxious is the blue over here. That's people that haven't been vaccinated yet, and even among kind of our healthcare workforce, not everybody's totally bought into this, and I think we really need to work on that. But what about monoclonal antibodies? So this is a treatment, and guess what? These monoclonal antibodies are directed at the spike protein. We've been working on monoclonal antibodies here. Mike Cohen, who I'm sure all of you know or have heard of, really, he won't admit this, but he really was the driver behind a nursing home study that I'm going to show you in just a second. I mean, it was done by a company, but he took their hand and led them to the study that I'm going to show you in a second. We know that if we give these monoclonal antibodies to people who have symptoms, if we give them early enough, we can prevent hospitalization. We can reduce hospitalization by about 70%. That's over here on the left. And in this study of over 1,000 people that were symptomatic, there were 10 deaths in the placebo group and no deaths in the treated group. And the NIH advisory committee has already come out saying we really should be giving high-risk people, older people, people that are obese, people with comorbidities like diabetes or renal disease or cancer. We should be giving these people these antibodies as outpatients. They're infusions, it's not easy. And I can tell you our healthcare system is probably doing a better job of this than almost any other healthcare system in the country. This is the study that Mike Cohen inspired. This is actually going into nursing homes where there's outbreaks and really giving all the clients, all the residents of the nursing home, this one monoclonal antibody. And the gray line on the left is number of infections in people that got placebo, and the blue line is the number that got the active antibody. And you can see the active antibody was very effective. 31 cases here versus 14 cases in the people who got the antibody. But I think the other thing is, again, of the people that got the active antibody, nobody died from COVID. And these data are going to be more complete. They're going to be published likely in the New England Journal very soon. This is a really important intervention, again, directed at that spike protein. At UNC, in the healthcare system, we've given over 1,600 infusions. And at the medical center, it's about 600 infusions. And this just shows you by day the infusions we've given. I was on a call with friends of mine at UCLA. Remember, UCLA is in Los Angeles. They had more cases than anybody. And they were very proud because they'd given 350 infusions. I didn't mention what our group had done. I was polite, but I wanted to. And then finally, here we're back to this spike protein. What about these variants, right? What about these variants? Well, the viruses, we think of them as smart. They're not really smart. They're actually the opposite of smart. They make mistakes all the time when they replicate. But some of these mistakes that they make when they replicate help these viruses. And we learned this beautifully with HIV, and now we're applying it to COVID. Some of these mutations, which are really errors in replication, lead to an advantage. And in the UK, this is the spike protein. This is that ACE, ACE up here. And what happens is when you get these mutations, antibodies that people have formed might not bind as well, or the virus actually attaches to that ACE protein better. And that's what we think about the UK variant. It's a little bit more efficient transmitting and maybe more virulent in terms of causing disease. And then there's this South African variant. And this is the one we're most nervous about, because these changes in the spike protein clearly decrease the ability of antibodies that people have formed when infected with the current circulating variant, decrease the ability of those antibodies to bind, not by a lot, but by some. And we know these variants are in the United States. The top one is the UK, the middle one is the South African, the bottom one is one from Brazil that's really a lot like the South African one, was selected for independently. The thing that's a tiny bit scary, that of these 46 variants of the South African variant, 21 are in South Carolina, 3 are in Virginia, 1 is in Tennessee, and 1 is in North Carolina. So more than half of the variants of this in the entire country are right around where we live. And the thing that makes people nervous is that if you look at how those monoclonal antibodies bind, and if you look how plasma, so I've been vaccinated by Pfizer. If you took blood from me and put it in a test tube, it would neutralize the current variant. And that's what's going on over here. It's neutralizing the current variant. So you can pretend that I'm one of these dots here. And it turns out that UK variant also neutralized by my plasma. However, over here is the South African variant, and well, it still does neutralize the, my plasma would still probably neutralize that virus, but not as well. So we're a little, we certainly are worried about that. And just here's what happened in South Africa. So South Africa had a variant like we have here, and they got another variant that was a little bit like the British variant, the UK variant. And then this little orange thing here is that the current South African variant. It's got a different number here, but it is the South African variant. And you can see in the space of 6 weeks, it kind of replaced what was going on there. And that's why I'm really focused on what's happening in South Carolina, and is this variant coming along. So maybe that's, I'm not ending on an upbeat message, but we will figure this out. We're thinking about this. The companies that make vaccines are thinking about this. We do know that some of our antibody combinations, like the Regeneron combination, which we are giving currently preferentially here at the medical center, does bind the South African variant. So we're on it. And I'm happy to answer questions, or I can wait till after Dr. Baratta, whatever's best for Leslie, who's in charge.
So Joe, we'll take a couple of questions now, both from ones that people had sent in previously, and then from the questions and answers.
Sure.
Somebody had already asked about the monoclonal antibodies and their use here locally, and you've described that. But for people that live regionally, if they get to that point, how do they get access to the monoclonal antibody treatments?
Yeah, we're pretty darn good at being kind of inward focused. So if you actually test at one of our diagnostic centers that have set up by the healthcare system, you actually get a my chart or a text saying, you know what, there may be a treatment for you and a phone number that you can call. So that's really great. I think where we could really use help is to be more outward facing to the community, especially people that don't have access to care. Now people can call the HealthLink line. There is a COVID helpline, but we need to make that more visible. And what we really need are a few navigators, kind of maybe nurses or nurse practitioners that can really help get people into care. We have that at the medical center, and they do a phenomenal job. So there is an on-ramp, but we could make that on-ramp better. And that's a really, really, really important question. So thank you, whoever asked that.
Okay, so next question for many in the group, or for some in the group, they've gotten both their vaccinations. And so now how do you go forward? How do you live post-vaccine?
Yeah, so a couple of things that we're not sure of. I have an opinion, but it's totally opinion. First of all, do we know that being vaccinated prevents infection? We know that it prevents symptomatic infection. And if you're lucky enough to get the Pfizer and Moderna, it really is super effective. And we know all the vaccines that we've examined so far prevent severe infection. So that's really great. But we don't know whether, for sure, whether people can still get infected and potentially spread to others. So I think right now we need to continue to be careful. We need to use masks as we have been, I think. Though if you're alone with your vaccinated loved ones, I think you're certainly safe in that setting. I think that we obviously good hand washing is great. I think the whole distance thing is a really good question. Do we really need to stay 6 feet apart if we have masks on? And I know a lot of people are asking that question. Can I go back to work if everybody's been vaccinated? Can students come to our classrooms if they've been vaccinated? We don't know yet. I would still be very assiduous about using my mask, and I'm still doing that. I'd love for us to be able to fully open up. I don't think we're quite there yet. My own opinion, based on some data from Moderna study, is that it does help prevent infection, probably not as effectively as it prevents symptomatic infection. But we are going to do some work. Some of it's going to be done here on our college campus to prove that we reduce infections and reduce spread. But that.
Okay. So there are a couple more questions that have come up about the vaccine itself. We talk about vaccines. You showed some data from each one of them. In your mind, is there really any difference between the Moderna and Pfizer vaccine? And then the second part of that would be just speculate on what you think about the likelihood that we'll need a booster.
So I think there's no difference between Pfizer and Moderna. That's the exact same message. That's my short answer. I think we will end up needing a booster, and whether that booster will have help us have broader responses, which is what we want. We want to cover all those variants. And I think that a corollary to that question, which I think was asked, is, well, how long am I going to be protected? I feel very confident that the data will show that we're protected for 6 months. And if you want my opinion, I think that those neutralizing antibodies, and in particular the B cells, the B lymphocytes that make the antibodies, will be around for a year. I think I think that really the bigger threat really is the variation of the virus, these quote variants.
Yeah. Okay. So a couple of questions about, or one on the vaccine. When are the studies for Moderna, Pfizer, Johnson & Johnson, Novavax, when are they going to go into kids? When do you see that being finished?
Yeah, being finished. That's a great question. They're starting. We're hoping that UNC will be a site for the Moderna vaccine in kids. They won't have to do. They're really going to be a little bit more of safety studies, so they won't need to enroll 30,000 kids. That would be really difficult. I expect maybe by summertime they'll be able to expand the indication to children under the age of 18 or 17. That's a total guess on my part, but that's what I think.
Okay, so one last question then about the antibodies. There's been a pretty low rate of uptake on utilization for them nationally. So just thoughts about why that is.
It really is logistics. It's all logistics. They have to be infused, so you have to have an IV. Initially, they were infused over an hour. Now that's been shortened, so you have to have some place you can sit for an hour, and then they wanted us to watch people for an hour after that. So it's a 2-hour infusion. You really and remember that people are actually going to have active coronavirus infections, so you really can't do that in a doctor's office. You have to have a setup. So it really is about logistics. And I think, the data are still pretty small, that, like the number of events is still pretty small.
Yeah.
So I think there's some, there's some skeptics. Also, I know, for example, I was talking to friends in Seattle, they really prioritized the vaccine. They knew antibodies they were going to get to those antibodies, but first they were going to prioritize the vaccine. So I think those are some of the issues.
Okay, good. So Joe, thank you. That was really good. So we're going to switch now to JM is going to talk about the recovery clinic here and just like post-COVID, what does it look like for people? So JM, thank you.
Thank you. Can you all see my screen?
I can.
Okay, great. So I'm JM Baratta. Thank you again for the opportunity to speak today. I'm going to spend my time discussing the road to recovery after COVID and a new UNC program called the COVID Recovery Clinic, which is designed to facilitate healing after this illness. So the updates that were just presented are overall, I think, great news about the diminishing new cases and rising number of vaccinations. I'm very grateful for that. However, in our rehabilitation practices, we are now dealing with somewhat of a second wave. That is, patients who have ongoing issues or symptoms even after their initial COVID infection has resolved. Many of you have likely seen or heard news reports about this new entity called long COVID, or also called post-COVID syndrome. You may have seen headlines similar to the ones that I'm presenting here, with some concerning words like puzzling effects, long-term ailments, etc. The affected group for long COVID has adopted the term COVID long hauler to, I think, describe their ongoing battles with an illness that in their cases it just doesn't want to let go. So this is a little bit of a busy diagram, but I just want to present it to you briefly to share with you the diversity of symptoms and medical issues that have been reported by the long haulers and that they continue to struggle with. And this diagram was published based on some data a few months ago. I think it could probably be expanded with many additional symptoms, but you can see that there's a wide variety of different parts of the body, including the brain, the lungs, heart, muscles, and other places that are affected. When I look at this, I'm really struck by the great diversity of symptoms listed here. So that leads us into the question, what is long COVID exactly? And there isn't one universally agreed upon definition at this time, since it is such a new syndrome. However, I think what is generally accepted is that long COVID represents lingering health effects of COVID-19, which can persist for weeks or months, or perhaps even longer than the initial infection. I shared on the last slide dozens of possible symptoms, but it does seem from our experience thus far that the most common symptoms include shortness of breath, fatigue, weakness, brain fog, which is a term that survivors often use, but they are describing difficulty with attention or memory as brain fog. A lot of people also have anxiety, stress, depression, and headaches. So it's important to note that the long COVID syndrome can occur in survivors who experience all spectrums of the illness, from mild to moderate and severe illness. And we're actually seeing at this time, the majority of patients presenting for this type of long COVID care actually were never hospitalized. They had a more mild illness, but still have persistent symptoms months down the road. So I expect long COVID to have significant effects on the people of North Carolina. Recent data suggests that a large percentage of COVID-19 survivors may develop long-term consequences. The first 6-month follow-up study from Wuhan, China was just published last month, and it showed that at 6 months after discharge from the hospital, only 1/4 of patients were totally symptom-free. That means that 3/4 of patients who had been hospitalized for COVID had at least one ongoing symptom still at 6 months out. We don't know all of the risk factors that are contributing to the development of long COVID just yet. However, it does seem that the risk is likely highest in people who were hospitalized, needed critical care like ICU level care, and also may have other health issues. I present a conservative estimate, I think, here of 40,000 long COVID cases that are already in our state. And I think this number will just continue to grow, particularly with the recent holiday and New Year spikes that we just made it through. As time goes on, I think this number is going to gradually increase. So UNC's approach to managing this new problem has been the development of a COVID recovery clinic. We are leading the way for long COVID care in North Carolina, as we are the first coordinated effort for long COVID in the state. It's been a very collaborative effort throughout the School of Medicine and UNC Health, including a number of specialties and disciplines which are listed here, which I won't read. And it has involved the participation and involvement of a lot of people, including the smiling faces you see here and many others who have been really integral to the development, but we didn't have the space to put on the slide. As we began the development of the clinic last year, I was really struck at how engaged and enthusiastic teammates were from throughout the School of Medicine and the health system. It is truly one great team, and I'm proud to be part of it. The way that the COVID Recovery Clinic seeks to provide care for the people of our state is addressing a variety of ongoing medical effects and also loss of functioning. And loss of functioning could be things like difficulty walking or performing daily activities. We are offering in-person and virtual visits. So this is accessible to people throughout the state. And we've already actually seen people from Hendersonville over in the mountains, all the way to Ocracoke on the coast. We offer coordination among specialists and we'll provide tight communication back to the primary care providers so they can stay in the loop. And we offer a holistic and multifaceted approach with the 5 things listed here in these blue boxes. We want to make sure to optimize and improve our survivors' medical conditions to help facilitate their recovery. We will address physical functioning and provide therapies and other exercises to help with their independence, endurance, and daily activities. We can assess and treat their cognition and memory to help with these frequent issues. And this goes back to the brain fog concern, which I had mentioned before. A lot of survivors also have issues with stress, anxiety, and depression. And so we're well positioned with the assistance of our psychiatry group to help to address these issues and provide some well-being. And finally, last but not least, we will work to help our survivors return to activities that are important to them. And this can be returning to hobbies, work, driving, or other activities. So we hope to be able to provide all of these different components for people who are seen in our clinic. And through this program, we also are looking to improve our understanding of long COVID. While the primary focus is providing the best care for patients in our community, the COVID Recovery Clinic will also include research and educational components. We're looking to develop cross-cutting research programs to study and improve long COVID care. And actually this Saturday, I was on a call with about 50 clinicians and researchers working together to develop methods to learn more about this illness. We will have a number of research opportunities available to patients, and all of these will be optional, and they will not affect any person's ability to get care in our clinic. However, what we've seen early on is that a lot of survivors are very excited about contributing to the research and helping to generate more knowledge. So when we do get a little bit better understanding of this syndrome, we hope to be able to spread this knowledge back to the community, both through implementing educational programming to medical providers and also the greater community of North Carolina. So I've reached the end of my remarks. I appreciate your time and attention. Happy to take any questions now or at another time.
So JM, thank you. That was really helpful to kind of understand the landscape of what happens post illness. A couple of questions related to long-term. One, are there so far any predictive factors about if I'm a patient with COVID, whether I'll have long-term symptoms or not? And then the second related question is, this is one of the coronaviruses. Do the other, and this could be for you and Joe, do any of the other coronaviruses really have these similar long-term effects?
Yeah, so I'll take the first question regarding the predictive factors. There are some predictive factors that we think exist, and that includes more severe illness, such as being hospitalized or needing to go to the ICU, and also having comorbidities like hypertension, obesity, and other comorbidities like that. This is a very good question, and this will actually be the subject or topic of very intense research in the coming months. There was actually a proposal, a request for proposals released just within the last 24 hours by the federal government, asking for researchers to look at potential risk factors. And UNC, through this clinic and through other patient populations that we've established, really hopes to contribute to this understanding.
Okay, so one of the specific questions that someone asked is about one of the side effects we've heard about is the loss of taste and smell. And again, for both of you, is that a big part of the long haulers? Is it more likely to go away in that kind of at-risk group that you're talking about?
I've seen some patients who do have persistent issues with smell and taste. I had one yesterday who hadn't actually lost smell or taste, but had an altered taste. She had a metallic sensation, and that was very disruptive to her being able to consume food and drink. So I think all things considered, it's a smaller part of the long-term syndrome, but it is present for some people.
Okay. So again, a question for both of you. One of the people ask about, there are a number of people that would have become ill with COVID symptoms, but because of the lack of testing, couldn't get tested. And so they didn't have proven disease, but now they have long-term symptoms. Are they going to be treated differently? How do we talk about that space?
It's an excellent question, and we have seen some patients who fit into that scenario in our clinic already. People who had the initial illness and checked all the boxes as far as the symptoms of acute COVID infection, but testing wasn't available, and antibody testing performed later on was thought to be potentially unreliable, so they were never diagnosed. I think that we will treat these patients in a similar fashion to the patients who do carry a COVID positive diagnosis. It is really about this holistic and multifaceted approach, as I was showing here, with focusing on medical issues, physical functioning, cognition, mental well-being, and returning them to activities. So I think that approach holds for both patients who have a COVID positive test and those who do not.
Okay. So one of the questions about long-term COVID-related issues around GI symptoms. So some have GI symptoms during the acute phase. Is that part of the long haulers? You talk more about the brain-related functioning.
Yeah.
Is GI like a bigger or smaller part, or not much of that?
Thus far, I've seen it be a smaller part. Some people do have some ongoing upset stomach and diarrhea in particular, even a few months out. But that is not that's not the most prominent, one of the most prominent features. The most common 6, I would say, are here central on the slide. They're really pulmonary issues, a lot of shortness of breath, fatigue, generalized weakness, this brain fog, some issues with mood and anxiety, and headaches. However, the other symptoms can potentially be involved. They're just not as frequent.
Okay. So Joe, I want to turn to you to ask you a question about like the other coronaviruses. So like they've been around a while. People here, fortunately, that you work with have been studying them a long time. What do we learn from that group of illnesses about kind of the space here with JM about, do any of those coronaviruses have long-term symptoms? And if they don't, why do these?
Yeah, that's a great question, and I've not heard someone ask it before, so I think it's really smart. All of us get these coronaviruses probably on like every other year. Like immunity lasts for about a year, and then we get it again. And I don't think it's a prominent problem because we have it. I think it's because, if I had to guess, I think it's because we all have kind of partial immunity to most of these coronaviruses as they circulate, and whether they're 100 or 500 years ago or whenever they came into the human system, if they were more like SARS-2 or COVID-19, I don't know. I certainly haven't heard with SARS-1, the original SARS from the early 2000s.
Right.
It wasn't prominent. That now many fewer people were infected, so perhaps it was missed. So yeah, I think there's something special about this virus. That's my opinion.
Okay, good. So, okay. Just as we come to the close of the hour, I want to thank Joe and JM for just taking their really busy time to stop and talk with us and share a few of their thoughts that they put together. They've, like, knowing in the background of what they've been doing for the last 12 months, it's an unbelievable, one, amount of work, and two, the progress that they've made and the impact on people has been pretty amazing. So I want to turn it back over to Leslie and let her have some closing thoughts.
Sure. Thank you so much, Dr. Burks, and thank you, Dr. Eron and Dr. Baratta. Wonderful presentation today. I just want to close by saying, if you are interested in learning more about what you heard today and supporting what you heard today, I encourage you to reach out to us. Philanthropy is what makes some of these things that we're doing here possible. I'll specifically call out the COVID recovery clinic that Dr. Baratta presented on. Our COVID-19 response fund did help and is helping to pay for some of the startup costs for that. So many of you on this call have already supported our COVID-19 response fund, and I want to thank you for that. And if you're so moved by what you heard today, please feel free to reach out to us, and we'd love to have a conversation. There's a few resources here on the screen too as we're closing out for you about coronavirus and certainly about the rise above COVID that we were talking about earlier. And then lastly, I'll just say there is going to be a survey as this session ends. So I would encourage you to just stay on for a couple of seconds and take that survey so we know what you liked or didn't like about the time that we had together. And we have 2 more of these sessions coming up in the next few weeks. So do stay tuned. The next one will be March 9th and past that March 23rd. So we will certainly be in touch with invitations for those events. So again, thank you so much for being here and for taking the time to hear from Dr. Eron, Dr. Baratta, and Dr. Birx.